How many cases do you have of the wrist and hand? Any only one? Or do you have any other? Right, only one. Okay.
So moving to hand and wrist examination, it is like your day-to-day practice where you will see almost 20-30 patients in your outpatient. And what it is this entire examination is for your covering your theory part of it, the practical part of it, and for the early into practice, they will also help to make it a good way to diagnose, assess, and help us to treat the patient properly. So this is like what we are hearing since this afternoon, that every examination with the joint, it starts with look, feel, move, and some tests which are relevant to that particular joint. And since this wrist joint is very much amenable for inject local, so you can do and specify the source or the pathology where it is coming from, because the wrist itself is a very complex joint, like any other joint in the body. You have 8 carpal bones, you have all the bases of the metacarpals, distal radius, distal ulnar, distal radioulnar joint. So this is the most complex articulation in the entire body, and the entire carpal bones are interconnected with different ligaments. So it makes little more difficult what is the source of pain, what is the etiology and all. So this lidocaine injection can eliminate the unwanted source, and that can help you to isolate. And what is the best tip of your thumb is your best part in your examination. Like everywhere, you use phone with your thumb, you use with your ID. I saw that there is one ID everywhere. So everyone, so tip of your thumb is your best friend here. So in order to understand what is the pathology, we divide this into 2 parts by drawing an imaginary line from the middle finger. Whatever the source on the ulnar side, we label it as ulnar sided pain. Whatever on the other side is a radial sided pain. And what are the typical source? You have tendons, you have nerves, you have arteries, and some intercarpal ligament which are holding all those carpal bones together. So how do you start? Suppose patient has the ulnar sided pain. So just don't go and touch the ulnar side. You start from the unaffected side. Why? Simply because it will help patient to be more, for examination. If you touch the tender spot, you will scream with the pain, and further examination is end. There is no further examination for certain severe patients, especially the middle-aged female, where the pain is disproportionate. So you always start from the unaffected side. Suppose this patient was having the radial side pain and I started from the ulnar side in a typical sequential manner. So this red dot here, if you see, this is the radial styloid, distal tubercle, distal radioulnar joint, ulnar head, ulnar styloid, and then sequentially all the carpal bones and the intercarpal ligaments. So this patient had scaphoid non-union, it was on the radial side. So always start from the unaffected side. Black box of wrist. So this is your theory part and along with your practical also. So this is triangular fibrocartilage complex. For your understanding, I have separated each and every ligament for theoretical purpose. We can clinically diagnose each and everything, but it will require more and more detailed study of the anatomy. So what are all those ligaments? The names labeled here. So just to make you understand, distal radioulnar joint, it has dorsal component, volar component, ulno-lunate, this is ulno-lunate ligament, ulnocarpal, and the ECU subsheath and meniscus homolog. So this is your theoretical part. For you to understand clinically, triangular fibrocartilage complex, it has two insertions. One is here at the base of fovea, and one is a tip of styloid, that is a superficial insertion. Which function of triangular fibrocartilage complex? Hold the distal radioulnar joint in position during pronation and supination, and it acts as a shock absorber. Because if you see on the X-ray, you will see ulnocarpal space, there is empty, but it is actually not empty. This triangular fibrocartilage complex is there, which will act as a shock absorber and rest of the having the proper biomechanics of the wrist. So how to diagnose this, all the wrist pathology? So there are at least 10-12 tests. I will tell you more relevant for a practical and theoretical examination. So how do you start? You start rotating the pure distal radioulnar joint. Just ask for you to passively pronation and supination. See what he is doing at the end? He is moving his little finger. So there is an intercarpal movement is also happening. We don't want to check the intercarpal region. We want the distal radioulnar joint. Passive or active pronation and supination. If there is no pain during passive or active pronation and supination, it directly tells you that there is an intact distal radioulnar joint and the peripheral part of the TFCC. Peripheral part means the part of TFCC which is attached to the tip of the styloid. Very common, TRUJ allotment. If that foveal insertion, the deep fiber, they are major stabilizer. If they are ruptured, indirectly this is called as a piano key test, very popularly known as a piano key test. But what is ideal is a TRUJ, allotment, distal radioulnar joint allotment. How do we do? Stabilize the elbow first, hold the distal radius and thenar eminence as a one unit with the one hand. Then with the other hand, hold the distal ulna and move in forward and backward direction in pronation, neutral and supination. And compare that on the opposite side. So watch this video. So checking both the side. Now asking patient to keep the elbow supported, hold the distal radioulnar joint. See how that is moving, how much allotment is present, neutral position. Now that compare on the opposite side. This is stable. Now ask patient to make a fist. All the muscles, they are preventing that. On the opposite side, it's frankly palatable. Even with the radial deviation, there is no restriction of the movement. Okay? So that is your TRUJ allotment test. Again, the same ulnocarpal ligament, part of TFCC which is holding. If you want to isolate, this is what patient will exactly tell with the TFCC tear. Foveal sign that they have pain on the ulnar side, especially when they press, when they drive the bike, And what is the test? You put them just into radial cavation. Look at this place. How much pain he is getting with this? And upon touching, yes, this is the site of the pain, and this is what MRI shows that exactly the ulnocarpal ligament of TFCC has been torn. Sometimes we don't have to do the test. Patient himself will demonstrate the test. What is it? See this. Patient himself is doing activity. So this is rare, but you should know this is a mid-carpal instability. When the ligaments between two carpal rope, proximal and distal, are ruptured, so there is instability between these two carpal rope. Two mobile joints in the CMC carpometacarpal. First is the thumb, that's why we have the full range of motion, and the fifth CMC. Unlikely fifth CMC has less pathology, but the first CMC has very common source of the radial side pain, especially the middle-aged to elderly female. They have like a OA knee. We have a OA osteoarthritis of the first carpometacarpal joint. What is the test? Hyperextension of thumb. See how much pain he is getting just with the hyperextension of thumb, and the reason he has post-traumatic arthritis of first CMC joint, malunited, neglected Bennett's fracture. This is what I was talking, degenerative osteoarthritis of the first carpometacarpal joint. What is the moment you see the difference? This is what is shoulder sign. On the affected side, almost first metacarpal has become like almost straight compared to the opposite side. See, it is looking like a shoulder, right? On the left side, that shoulder sign is completely lost. Other test, you hold the metacarpal and try to grind against the trapezium. Patient will have the pain. So this was the X-ray of the same patient. It's a severe osteoarthritis of the first CMC joint. Now, moving to the radial side. Most common, I would say not most common, the second most common cause of radial side pain is the rupture of the scapholunate ligament. Very common injury amongst the wrestlers when the hand goes into the twisting in mode. So this scapholunate ligament is ruptured. What is the test? Watson's test. Hold the wrist in ulnar deviation, keep your thumb on the scaphoid tubercle, and just what you do is flex move from ulnar deviation to the radial deviation. What happens? Scaphoid will try to flex, but your thumb will not allow the flexion. So scaphoid will jump out dorsally, causing the pain and the click, indicating there is a scaphoid lunate ligament is ruptured. And this is what you will see on the X-ray. The space between scaphoid and lunate is increased. It is called as the Terry Thomas sign, named after the British comedy. STT arthritis means scaphoid trapezium trapezoid arthritis, rare, but that you should know. Very common. This is what you must know from your exam point of view. These four. Can anyone tell me what is it? Simple. What is tenosynovitis? Yes. Inflammation of the synovium. Tenovaginitis. Inflammation of the content. A1 pulley. Trigger finger. Tendinitis. Inflammation of tendon. Tendinosis. Yes. Degeneration of the tendon itself. So these four terminologies you must know. Most common tenosynovitis. Decurvence. What are the tendons involved? Loud. Loud.
EPL and ABP. EPL and
Yes.
ABP. EPL and ABP.
EPD, yes, and correct. Not extensor pollicis longus. So this is what examiner will ask you. Only two things. What are the compartment? The wrist is a Pepperpolis longus and extensor pollicis brevis. Test, Finkelstein test, to ask patient to do this thumb in palm or take the wrist into flexion. So it will cause more expression of the tendon and will have more pain on the radial styloid of the snuff box. So again the same, tenderness at the first dorsal compartment, Finkelstein test. Similarly, other tendons can also have synovitis. So what you do, put all the tendons into their stretching mode and ask patient to do that action what that tendon is doing. So same for the flexor tendon, same for the extensor tendon. So long extensor, EDC extensor, digitorum communis, pain on extension of long fingers. That patient will complain of the pain. So every finger extension, that patient has a pain. Extensor carpi ulnaris, it has a similar but little different test, is resisted abduction of the little finger. That is a synergy test. Right? Doing this abduction, resisted abduction, patient has been, very classically patient will tell where is the location of the pain. Again, sometime you don't have to do the test. What is the diagnosis? See, watch it carefully. What is happening with every pronation and supination? Correct. ECU, extensor carpi ulnaris, is snapping with every pronation and supination. So that is jumping ECU or subluxation of ECU from its bed. Don't have to do the test, patient will tell. You just have to tell what is the next thing. Very common, trigger finger. Don't get confused with the trigger finger, long-standing trigger finger especially, which will lock in flexion with a dupuytren's contracture. I have seen a lot of patients who has been treated with trigger finger, but underlying they have dupuytren's contracture. They come that the surgery was done, but it is not my finger. I'm not able to extend my finger. Okay, classical early stage they will have click with every movement, and there will be palpable thickened A1 pulley as a nodule. Theory question: 4 cardinal signs of Canavan. Flex attitude of the finger, fusiform swelling, tenderness along the flexor sheath, and painful passive extension of affected digit. These patients, even if you touch on the lateral side, the radial side, dorsally, they will not have pain at all. Moment you touch the volar side or the flexor side, they will have a lot of pain. Okay, 4 cardinal signs, theory plus practical, both. Same patient, trained abscess, turn out to be Morin tuberculosis. Again, same, flexor side, stretch the flexor tendon, patient will have pain. Malrotation, not acceptable. This is what you are supposed to see when the patient comes in the casualty, whether this patient needs treatment or not. This scissoring effect, the little finger is also turning. All these need surgical intervention. So we all know how the extensor tendons are formed. Long extensor tendon at the level of metacarpophalangeal joint. They form extensor hood. Action is extension of MCP joint. This is lumbrical and interosseous getting inserted, form the extensor hood. Same tendon continue, insert at the base of the middle phalanx, that is the central slip, and it gives 2 lateral slip which go and insert at the distal interphalangeal joint. Central slip causes this action, extension at PIP. Lateral band causes extension at DIP. What happens subsequently? Now this is the wrist injury. Okay, all finger drop. This is not wrist drop. Finger drop post surgery at the wrist. You see those scar mark at the wrist? Sharp object at the metacarpal head. Single isolated finger drop. Central slip rupture. no active extension at PIP. So this is the same patient, and post-surgery active extension possible. What is it? Mallet finger, right? Isolated FDS and FDP, middle finger, ring, and the little finger. They have the one continuous sheath. There is isolated FDS and FDP for the index finger. So how do you test? Active extension at PIP is by FDS, flexor digitorum superficialis. FDP, hold the PIP joint and ask patient to flex. So this isolated action is FDP, flexor digitorum profundus. So this is a little advanced. You see post-surgery, post-distal radius fixation, or with a slab, plaster cast, whatever we put, and this patient sometimes develop the stiffness. So how to isolate that stiffness is because of the capsule tightness of the metacarpophalangeal joint or the interphalangeal joint. So this test is Funnell's test. So with full extension of MCT, you ask patient to do the flexion. Okay, IP joint are getting flexed. But if you ask the same patient to flex the MP joint, but IP joint means interphalangeal joint are not getting flexed, that indicates intrinsic tightness at the lumbricals or the introshaft. So that is intrinsic tightness because of the post plaster cast patient was given for the distal radius fracture. Very, very common. Right? This is, I think, the same case that we are going to discuss. So two tests, balance test and Durkan's compression test. We will discuss that when we discuss the patient care. I will not go into detail of this. Similar Guillaume's canal, ulnar nerve compression. Patient will have tingling sensation, ulnar nerve distribution. So this is the same patient we will discuss again while discussing the case. Ulnar nerve, ulnar claw, pointing index, isolated entry introosseous nerve injury. So this patient has an elbow dislocation, and post elbow dislocation this patient is having pointing index. So this is the introflexure. The median nerve at the level of elbow was entrapped between the fracture fragment, which subsequently related the release and internal neurolysis. Wrist drop, Wattenberg, finger drop. What is this? There is no active extension of the thumb. Patient is able to do wrist extension, but no active extension of finger. Active extension possible. This was for the some implant removal. Is it a radial nerve or posterior introosseous nerve? What is it? Exactly, not the wrist drop. Wrist is able to do the active extension. Now watch this very carefully. We hardly do this test before doing any surgery on the wrist. Distal radius fracture, I'm sure you must be operating every day, right? But we hardly check. We just mention no DNVD, no distal neurovascular deficit. So watch this test. How to do? Ask patient to make a fist, block radial artery with one thumb and with the other ulnar artery. Now release the fist, release one thumb, see the color of the palm, it is still pale, still yellow, and see what happens now. It turns pink. Right? So the radial artery is not patent. Radial artery has some problem which we must document preoperatively. Otherwise, blame goes to you. Because of the surgery, something went wrong there. Okay, so this is in short what I have to discuss about the hand and wrist. I think there is one thing you must know last. How to measure the strength. Can anybody tell what is it? what is this instrument and what is this used for. This was asked to me during my MS exam. I couldn't answer by the way. I would have got the gold medal then if I would have answered this. So this is a pinch meter, right? It is used to measure the pinch strength of the hand. Similarly, there is another thing. So you ask patient 3, 1, 2, 3, and you take the average of that and you compare that opposite. So this is a dynamometer. Grip strength, how to measure the grip strength. So this you may find in your occupational or physiotherapy department. So you must know this. This would be part of your table instrument during the exam. Alright, this is what I have to discuss. Thank you. So anything you want to ask or we should proceed with the examination? Who is presenting without